Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain. We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Bienvenue, and welcome everyone to the March edition of Family Medicine Grand Rounds. And today's speakers come to us from Montfort. And so welcome everyone. I can see a lot of new faces, and that's terrific to see. So without any further ado, we'll begin. Maddie présentera notre première présentatrice de la session, la Dr. Haykal. Maddie will present our first speaker of the session, Dr. Haykal.
La docteure Haykal est la doyenne adjointe au service aux étudiants depuis juillet 2016 à la Faculté de médecine de l'Université d'Ottawa. Elle a d'abord obtenu un doctorat en optométrie de l'Université de Montréal en 2002, puis un doctorat en médecine de l'Université d'Ottawa en 2006. Elle est médecin de famille, membre de l'équipe de santé familiale académique Montfort et hospitaliste à l'hôpital Montfort. Depuis le début de la pandémie, elle présente un sommaire régulier au sujet de la COVID-19 sur les ondes de la station radio CHIN. Elle se passionne pour l'enseignement, la découverte de soi et la promotion de la santé, tant auprès des étudiants et des résidents que des patients. Bienvenue, Dr. Haykal.
Alors, bonjour tout le monde. Thank you for being here this morning. I was asked to present to you about my research. My research projects stem from my academic position at the Student Affairs Office. For the purpose of this presentation, you will notice that my slides will be in French, but I will be speaking in English and also in French. So to try to make this presentation as bilingual as possible. So feel free to ask me any questions in French or in English. Next slide, please. This is a quote from the 2019 Canadian cross-sectional study results. In 2015-2016, the authors conducted a survey of medical students in all years of study in the 17 Canadian medical schools. The survey included validated items and instruments to assess psychological distress, suicidal ideation, and diagnosed mood and anxiety disorders. Ils ont fait des comparaisons entre les étudiants en médecine et la population postsecondaire générale. So they compared medical students to similarly aged post-secondary graduates. In conclusion, they found that compared with post-secondary graduates from the general population, medical students had significantly higher rates of psychological distress, suicidal ideation, and mood and anxiety disorders. Donc, ceci nous amène à conclure qu'on a besoin de plus de recherche pour savoir quels sont les facteurs qui peuvent contribuer à ces taux augmentés en médecine. Unfortunately, as you know, the results are not surprising to many of us in the field and tend to be similar globally as well. Next slide, please. Donc, nous, à la faculté de médecine, au niveau de notre bureau, on fait des évaluations de bien-être. At the Faculty of Medicine of the University of Ottawa, the Student Affairs Office has a mandate to ensure the wellness of the students. The Wellness Check program was created and is run by the Student Affairs Office. And the goal of this program is to help students assess their personal well-being, to help them set and achieve personal goals, and to facilitate access to multiple resources. Donc, le but, c'est d'assurer leur bien-être, qu'ils puissent atteindre leur but personnel et de découvrir les ressources disponibles et qui sont à leur disposition. What is the wellness check? Back to the other slide, Maddie. I'm still on that one. Thank you. So the wellness check consists of a 30-minute meeting with a counselor to review 10 main domains of wellness. And this is aided by a self-assessment questionnaire that is completed prior to the session. The wellness check is completed in year 1 and in year 3 as well. The difference is that in year 3, students meet with a counselor on an as-needed basis if we identify risk factors or red flags following the review of their wellness checks. Next slide now. Thank you. With the support of the AFP à l'hôpital Montfort, j'ai eu l'opportunité de faire un projet de recherche. Donc, through a research bursary, I started a research project 3 years ago. Using the data from the wellness check questionnaires, the main objective was to determine what are the risk factors for mental health in medical students. Donc, le but, c'est de déterminer quels sont les facteurs de risque pour la santé mentale des étudiants en médecine. The secondary objectives were to determine if there is a variation of mental health and its risk factors depending on demographic variables, as well as to look at the mental health between first and third year of medical school. Donc, voir s'il y a un changement dans la santé mentale entre la première et la troisième année. Next slide, please. Here is some information about the questionnaire. So it is inspired by the Mayo Clinic Medical Student Wellbeing Index, but it was modified from other resources as well for the purpose of the program. It is composed of 40 to 45 Likert Square questions centered around the pillars of wellness, which you can see here, and those are physical health, sleep and fatigue, social support, finances, studies and career, drug stress, and alcohol. Psychological emotional health is considered our dependent variable in this project. The questionnaire varies between year 1 and year 3. There's about 40 questions in year 1 and 45 questions in the year 3 questionnaire. And this questionnaire was started before I got into the position. It was not mandatory in the first years of the program, and then it became mandatory afterwards. Following that collection of the answers, they were converted on a numerical scale and statistic analysis was done. Next slide, please. So this was a cross-sectional study with 911 students who completed the questionnaire. And the total number of participants was 905 because we removed the students who did not consent to have their information collected. Donc, parmi les 905 étudiants, il y en a qui sont en première année et il y en a qui sont en troisième année. If you look at the first chart on the left, you see that the participants are from MD 2020, 2021, 2022, and 2023. So 4 different cohorts. In the chart on the right side, which represents year 3 students, you see the cohorts are MD 2020 and MD 2021. So you're probably asking yourself, why is that? So as I said before, the wellness check was not mandatory when the MD 2020 students were in first year, explaining the smaller number of participants in that cohort. We also had a lower number of third year data because not everyone completed the wellness check in year 3. The cohort MD 2021 would be the only cohort that completed the questionnaire in year 1 and year 3. So that would be the only cohort that we can follow from year 1 to year 3. That's because that that wellness check became mandatory for that year. Next slide, please. In terms of results, donc lorsqu'on regarde les résultats de risque, de facteurs de risque pour la santé mentale, risk factors for mental health statistic analysis was done with linear multiple regression. In combined first and third year results, the most significant risk factor for mental health, as you can see here, sleep and fatigue, as well as studies and career, and also stress, drugs, and alcohol use. Next slide, please. So let's compare year 1 and year 3. Donc maintenant, on fait une comparaison entre la cohorte qu'on a pu suivre dans le temps. Donc ceux qui ont complété le questionnaire durant leur première année et par la suite durant leur 3e année. When looking at results, we can notice that there is a difference in significant risk factors between first and third year. For example, social support is the most impactful risk factor in first year students, but is not even statistically significant factor for third year students. Physical health, la santé physique, seems to affect third year students only and is not statistically significant for year 1, which is why you don't see it in the first year graph. De façon étrange, les finances semblent être corrélées de façon inverse. Donc, it's a little bit strange that finances are inversely correlated to mental health, which was unexpected. But like many of the results from this research, we weren't expecting a lot of them. Next slide, please. We also had a second objective, which was to determine the variation of mental health and its risk factors according to demographics. So we used a t-test for multiple sample statistical analysis here. A higher score for us would indicate healthier students in those different categories. So for example, students from Ottawa, when we looked at demographics, tend to have better social support and less stress and use less drugs and alcohol than students from out of town. Donc, la santé mentale pour les étudiants qui viennent d'Ottawa était meilleure. Ottawa is unique with its French and English streams. Again, here, physical health tends to be better in the French stream, but psychological, emotional health is significantly lower in the French stream. Donc, la différence entre les volets francophones et anglophones, c'est que la santé physique était meilleure dans le volet francophone, mais la santé psychologique et émotionnelle était plus basse dans ce volet-là. Finally, for women, we saw that there is a lower average in the scores in all the categories, except for social support, which does not have a statistically significant difference. Next slide, please. We then compared students between their first and third year using a mixed linear model with repeated measures, statistical analysis, and also found that when covariables are considered, there is no statistically significant difference in the psychological or emotional health for students in year 1 and year 3. However, when the covariables are not considered, students have a lower average score for mental health in their first year and not in their third year as we would expect. This leads us to the possible conclusion that students in year 1 have a lower mental health than students in year 3. Donc, dans ces résultats-là, lorsqu'on regarde la santé mentale entre la première et la troisième année et on ne considère pas les covariables, on peut voir que la santé mentale des étudiants est plus basse en première année, possiblement pour nous faire conclure que la santé mentale s'améliore et on peut penser aux raisons, mais le but, c'est pas d'aller dans les raisons ce matin, c'est vraiment de présenter un peu le contexte de la recherche. Next slide, please. Following the research of, following these results, I think it's important to talk about the limitations of this project. So firstly, we do not have any information about the psychometric properties of the instrument that we were currently using for the wellness check. It is difficult to determine if the differences that we find or that we don't find, that we were expecting to find and didn't find, are related to real differences in medical students or artifacts due to the instrument itself. Donc, étant donné qu'on ne connaît pas les propriétés psychométriques de l'instrument, c'est difficile de comprendre si les résultats sont réels ou ce sont des artefacts. Furthermore, the questionnaire is a mixture of questions from different sources that are English. So this makes it less reliable to be administered for the Anglophone stream, for the Anglophone students, because of the different questions coming from different sources, but also for the Francophone students, because this was a translated version that was not validated either. And we can conclude that the absence of a valid and reliable instrument for the measurement of wellness supports would require further research to be done in order to get more reliable and validated results. Next slide, please. So where do I go from here? With the support of the department through the DFM New Innovator Award, I am excited to expand further on this. So the goal in the upcoming years are to identify a validated questionnaire for wellness from the literature, or to validate the existing questionnaire with data from previous years. Of course, that can be a little bit more difficult. I would also like to do an annual wellness check for students in their first, second, and third years with the new questionnaire. This way we are able to compare as they move from year 1 to year 2 to year 3. Currently, we don't have that wellness check in year 2. Afterwards, we can identify the risk factors for mental health and determine if the mental health of the students improve, deteriorates, or remains unchanged from year 1 to year 2 to year 3 during those 3 years of education. Finally, the goal is to use these results to develop robust and individualized strategies that can be used to meet the immediate well-being needs of medical students along their training curriculum identified by the study. Le but, c'est de suivre les étudiants, comprendre comment leur santé mentale change de la première à la troisième année, mais aussi développer des stratégies individuelles et robustes qui peuvent aider les étudiants pour leur bien-être et leur santé mentale dans l'immédiat et dans le continuum de leur éducation médicale. Next slide, please. So this is the end for my presentation. I want to thank you for listening. And also, I want to take this opportunity to thank you for all your hard work during this last year. So please stay well. Thank you.
So without further ado, I can see a couple of hands up. Lynn, let's start with you.
Alors, merci. Merci, Kayane. C'est super, super intéressant ce que tu fais. La question, je ne sais pas si tu l'as dit ou c'est juste moi qui étais distraite, mais dans ton questionnaire, est-ce que tu poses c'est quoi les techniques que les gens ont personnellement pour essayer d'avoir une santé mentale plus saine?
Merci, Lynn, pour la question. Donc, les questions sont vraiment basées sur les différents domaines que j'ai expliqués et on ne cherche pas à comprendre quels sont leurs moyens d'aider leur santé mentale. Donc, on pose des questions spécifiques par rapport à leur santé physique. Donc, est-ce qu'ils font des exercices?
Okay.
On pose des questions par rapport à leur consommation d'alcool. On pose des questions par rapport à avoir des idées suicidaires ou avoir pensé des pensées dépressives. Donc, c'est vraiment, on n'a pas regardé quels sont les moyens pour améliorer leur santé mentale, mais ça serait une excellente façon de peut-être poursuivre et pousser plus loin aussi.
Oui, c'est ça, parce que ça pourrait peut-être expliquer un petit peu pourquoi il y a des niveaux de résilience différents, si tu es en première, deuxième, troisième ou quatrième. Oui. Ça l'aiderait peut-être avec les outils que tu veux développer. Mais très, très intéressant. Merci.
On a un programme de résilience et on pose ces questions-là dans le programme de résilience, mais ces deux programmes-là ne sont pas interreliés.
Okay.
So Dr. Pitre asked if in our questionnaire, we have questions for the students in regards to what are their methods or their ways of improving their mental health. And I answered that currently the questions are in relationship to the different domains in order to assess their well-being, but we don't ask them about the tools that they utilize to improve their mental health. We have a resiliency program, which is composed of a workshop in all 4 years of medical school. And during those workshops, we ask them pre and post workshop. We do pre and post workshop surveys where we ask about their resilience and how they work on their resilience and what methods they use. But these two programs are not related in terms of the research that we're doing, which maybe we should use that later on.
Claire Kendall.
Great presentation, Kayane. Merci for presenting to us today. I'm just thinking about just the robust way you've collected this data and thinking a bit about Bill Hogg's, some of Bill's work in exam findings. I guess that's more primary care exam findings, but is there any way to know or to look forward once you've got this new scale to say, okay, now we can see that more well students actually perform better, or students who have certain experiences in undergraduate medical education end up performing better, like, you know, one direction or the other? Just curious if you've thought about extending your work that way.
Thank you, Claire. That's an excellent question. So I would have to say that Dr. Hogg was very helpful in continuing my research, and he encouraged me to do so. So I think it's very, very important to be able to look at it from that perspective as well. I saw a question about when we administer the questionnaires as well coming up in the chat. So I think comparing the students in their 3 years is one thing, but also looking at the background of the students is very important. And we collect that information in the demographics. Now, how do we use it to analyze the results is probably important as well, based on what undergraduate program they come from, what they've done in the past, if they have just a 3 years bachelor degree versus if they had a graduate degree. I think it's very important to look at that. We didn't for the purpose of this collection of results, but I think it's a great idea to look at that. And I should be writing all those great ideas down. Thank
and
you.
just acknowledging, like, sorry, just follow up if I can, Doug, that, you know, as we move through curriculum renewal, are there aspects that, does it change wellness, right, ways that we structure things, and just acknowledging also your really incredible work in wellness in the undergrad program. We know that Ottawa has a really hands-on, one-on-one, with Kayane being the go-to for our medical students. So just acknowledging that as well.
Thank you, Claire. I think we're doing this, we're also looking at the wellness components in our curriculum and trying to adapt our wellness program so that it's more longitudinal as well, and how we're teaching it in the 4 years, because it's important. I think maybe one of the conclusions that we came to is that we have a lot of supports in year 2 and in year 3 for medical students. Maybe we have less supports in year 1. And as the students also create their social network and move to year 2 and year 3 and year 4, maybe that's another component of why their wellness seems to be better or not changed. So that could be another reason, but it's important to look at that more specifically.
Great. Thank you very much. So next we'll have Claire Liddy and then Simone DeRouge.
Good morning. Félicitations, Kéan. C'était très impressionnant. So great work. I have a comment and then I have a question. So my comment is just, I think, Kéan, you are a great example of how you have an area of interest in terms of your day-to-day work, and then you've turned that into examining and being curious and looking at some scholarly questions, which are, I think, with the comments and everything people are suggesting, you could see this could end up being your work over the next 10 years, so, or even beyond. So so good for you, and keep going with it. My question is whether or not in this work and with your research team, do you have medical students who are part of it? Could you speak a little bit in terms of that perspective and how you incorporate them into your project? Thank you.
Merci beaucoup, Dr. Liddy. Merci pour votre encouragement. C'est très apprécié. As you know, I am not a researcher. I am a clinician, and this was actually one of my passions, mental health. Even during my residency, I did my scholarly project on a post-traumatic stress disorder. So, and then I continued working on wellness initiatives. So I think that's just, as you said, one of my interests. Medical students have been involved. They're involved on every summer. I have a medical student who works with me on one of my projects. So I've had a medical student involved in the collection and analysis of this data for the last 2 years. And she's very impressive because she understands all the stats more than me. So I learn a lot from the medical students. And also the medical students are very keen on doing research and having publications and doing literature reviews. And so they're very involved in that sense because they want this to be on their CV, but at the same time, it's very helpful to have that support because in my position, I have the day-to-day work and I have to ensure that the supports are available. And I also have my patients. And so having a medical student who has a real interest in that is very helpful. So I've had a student bursary in last year and the previous year, and that is actually amazing. So anyone who has research projects going on and is interested in having those amazing medical students work for them, there's always opportunities at the faculty through the UGME office, through the research office, through the wellness office. There's also new bursaries as well. I think I'm very lucky to have them work with me. They are really, really amazing.
Thank you, Kéan. Quick question, Simone.
Je vais essayer de faire ça rapidement. Félicitations, Kéan, c'est formidable. Écoute, j'ai peut-être manqué un petit bout que je n'ai pas entendu au début, mais ce que je me demande, c'est l'objectif principal de ton programme. Is it to be able to identify issues so that you can act on it? Is it to be able to understand how these issues or these concerns relate to the student's performance? And so I would say that determining that will help prioritize whether you should be linking things to you know, to different programs and how you might validate, because I still heard you say that there's some concern around the validation. It wasn't validated in French and some of the new items wasn't validated. I would think that if you wanted to develop something that you can act on, I would prioritize validating, you know, doing some validation work, and how it gets validated, ça va dépendre de l'objectif, ton objectif principal.
Merci beaucoup, Simone. C'est une excellente question. So the purpose of the wellness check is not to link this to academics, because the Student Affairs Office has no knowledge of the academics of the student. And we're completely separate from the rest of the UGME office. So unless the student shares that information with us, we have no way of knowing that part of the portfolio of the student. The goal is the main goal for why this was started and why I believe it's important to do this wellness check and make it mandatory is to identify any students who are at risk and any risk factors for that specific student, so we can provide the appropriate resources and the appropriate support. Does that answer the question?
Oui, alors je prioriserai la validation de celle-ci. Alors, si on découvre quelque chose dans le sondage, est-ce que effectivement il y a un problème? Est-ce que c'est le genre de problème qu'on peut aider à résoudre et tout ça?
Excellent, merci.
But I would like to take this time now to introduce our second speaker, and that is Dr. Pierre Tessier, who completed his residency in family medicine at the University of Western Ontario. He also completed an MDA from Queen's. He was the original family medicine residency coordinator at the Montfort from 91 to 93, and remained an educator in the residency program up until now. He has held a private practice in Ottawa, migrated to a family health team from 2002 to 2010, and started doing collaborative solidarity family medicine in Chile for 6 months, a year since 2010. Concurrently, he's changed his practice to be a hospitalist at Montfort with locums and family medicine during the summers. He considers himself a neophyte at research, but willing to embark on this new adventure. And from his work as a hospitalist, he is quite involved in geriatric care, management of multimorbidity and chronic disease, as well as palliative and end-of-life care. He's interested in optimizing care resources for the elderly, specifically for patients who are residents of long-term care facilities. So Dr. Tessier, welcome, and thank you for presenting.
Thank you, Doug. I want to emphasize the fact that I'm a rookie at research, and I'm just trying to expose to you what evolved from being a pet peeve to a research project. I've had a very varied professional trajectory over the last few years, and you know, you tend to observe things, and some things come to annoy you a little bit. So I'm just thinking maybe we can push this a little bit further. Another of my ideas or motors in doing this, what is to this point an observational study or analysis, is also thinking about the education of our future physicians. We know that the demographics are changing at a very rapid pace, and whoever is an MD 2021 will have to face like a tremendous challenge in looking after the elderly and an ever-increasing proportion of the population in this demographics or in long-term care. So being that we're in a teaching hospital, I felt that when we are actually dealing with patients who are multimorbid at the end of life, extremely old, like the 4th generation, more or less, are we doing a very good job at, one, looking after them, and 2, are we doing a very good job at teaching our students how to look after them? So this is sort of the dual path that I'd like to pursue with this observational study. I want to acknowledge, maybe, will Maddie move the slides, please? Okay, So I want to acknowledge that I had the assistance of a medical student, candidate 2021, who was like an energizing force to do this this observational study. Just as an example, I mean, she was traveling in Southeast Asia, and we were still communicating because she still had in mind the project as she was preparing to present a poster in September at the research day. So thank you very much to Anne-Marie Friesen. We did this study, and I'll talk to you about the methods we used. We basically interviewed. First of all, we started this with the idea that this was a pet peeve of mine, as I say, as working as a hospitalist, to see that we had probably many unnecessary admissions to Montfort Hospital, coming from our catchment area of different long-term care centers, and one had tended to wonder if we really needed to use hospital resources, acute care hospital resources for these patients, or if there was an alternative way. And again, the length of stay sometimes was tremendous. So we started looking at the factors that could be involved in the decisions to transfer, decisions to hospitalize. And the third step would be to try and reduce the acharnement. And I've tried as much as possible to find translation for acharnement. I know Maddie came up with futility of treatment. That's probably a part of it, but there's a dimension which is not really well translated, that can't be translated very well. So we were looking at this, and then of course COVID hit in March 2020, which changed the dynamics between long-term care center and hospitals by virtue of transferring, not transferring, having to extend hospitalization length of stay because we couldn't return patients to their long-term care centers. So in this sense, our study, the impetus of the study was unfortunately frozen because of external factors. I come at this, as I said, as a hospitalist. I have done work in long-term care centers over the years, mostly as replacement for colleagues. So I have a bit of an idea of the dynamics and the conjuncture at the long-term care centers. Although I have to say I haven't been involved in a very consistent way over the years. So that's more or less the premise, Maddie. So we want to thank the people with whom we held interviews. This was a very qualitative study based on interviews from directors of care in 3 centers which are in the Montfort catchment area. Obviously, there's not a direct link because many of these, the patients from these long-term care centers also end up in other hospitals in the city. Had conversations with nurse practitioners, and I'll come back to this a little bit later on. There's no conflict of interest. It was sort of purely by professional interest. So the initial statement, or the raison d'être from this study, was that we felt that there were many people who were hospitalized in acute care hospital for reasons that were more than likely avoidable. I alluded to the fact of sometimes tests and examinations and a length of stay that is often without a clear goal, and certainly not is disjointed from the goals of care, which are and should be clearly stated in the file at the long-term care center. So what we see here is a disjointed plan of care once people come in the hospital. This leads to doing probably too much for people who are, let's face it, many times at the end of their life. Obviously, if they've been admitted to long-term care centers, it's because they're severely ill and severely dependent. So that perspective, I think, might be lost from one environment of care to the other. We cannot make abstraction of the fact that there is a huge financial burden to the healthcare system. These people, as they enter the hospital for acute care, are basically occupying 2 beds in the healthcare system. And to these 4 points, I also want to add the fact that as teachers, we should be doing, I think, a better job at putting this problematic in perspective for our medical students who, as I said before, will be faced with even more challenges in looking after the very old and very ill people in their medical career. The objective was to basically look at factors that come into play in the decision to transfer to hospital care, and maybe identify some pivotal points that where we can actually probably intervene to optimize the care to these people without using undue resources. So we conducted, as I said, a method. Like our method was to basically ask directors of care what they saw as being issues, significant issues in the decision to transfer. Next slide, maybe. Okay, we talked to nurse practitioners because there are programs, and as I said, we'll get to this a little bit later in my conclusion, who are involved either remotely or within the long-term care centers. Very interesting discussion with the paramedics. We know that paramedics are now playing an even greater role, even in the continuity of care in the city, at least. There are projects that have started in other cities in Ontario, Hamilton being the forefront, whereby people can actually check in on people, mostly at home, but maybe this is something to explore from the long-term care center point of view. And also, as a pivotal point, I've had long discussions with the director in our emergency at Montfort. Of course, the impetus, as I said, was the clinical practice and observation of cases, which are unfortunately very frequent and seem to be even more so now because of the situation of COVID, whereby people are sometimes staying for weeks at the hospital, just waiting for the outbreak in their long-term care center to finish. Good. This is not reinventing the wheel. Obviously, all the factors that I mentioned, especially the economic factors, are big drivers to look at this problematic. The Health Quality Ontario, under its quality initiative programs, has been trying to look at this. Obviously, this also has stalled because of COVID, which has changed the rules of the rules of the game in terms of transfer of patients and so on. But they have issued a document, which is quite interesting, which lists a number of conditions for which care could probably be optimized in the long-term care center without having to use acute care hospital resources. So this, as I say, this is not new. What we want to do is basically look at what we can do locally with centers in our catchment area to try and optimize care. There is a program from the LIN, next slide, the Champlain LIN, which involves nurse practitioners. The LIN has funded the presence of nurse practitioners in a few of the largest long-term care centers to be resources of consultants to assist the RNs or RNAs, who are, of course, the main caregivers in the long-term care centers. There's also a project at the Civic, which the Champlain LIN funded, whereby nurses are based at the Civic Hospital, but are the consultants for 3 or 4 long-term care centers. And they basically are phoned by the nurses who are at bedside, and they're asked for advice. And many times these nurse practitioners will actually leave their base at the civic hospital and go to visit patients. This is, of course, a fairly costly program, but in the end, after 2 years of implementation, they have figured that even with all the resources of 4.5 nurse practitioners, they basically have been able to reduce the number of transfers, and the economies have been major, even if the program itself is quite costly. There has been an attempt at locally at creating algorithms of care for different problems, but there are many factors to which I'll come to, which come in the way of implementing these algorithms. That's what we've discovered by our interviews. So we started off with a bibliography, and I have to thank Mrs. Louise Laberge at Montfort, who did a superb job at finding what is a fairly ample bibliography. This is a problem which is universal in developed countries. We know that in developed countries, we have a tendency to institutionalize people who are elderly. In my work in South America, it's quite interesting because it is talking about placement of an elderly or a very sick person in a center is seen as an insult to the family. So you see the difference in paradigm that we have here, where it seems to be the norm rather than the exception to actually institutionalize are very ill. And from that point, well, of course, there's the relationship between long-term care centers and acute care hospitals. So countries like Scotland, UK, the USA have done analyses which are both in terms of analyzing the care, and also in the context of economics, which is a major issue. So now to the crux of what we observed. This seems a little bit daunting, but I just want to explain a little bit where we found the pivotal points upon which we may want to pursue a little bit more analysis. The family of the patient, either the patient themselves or the families, play an important role in orienting the care. There is, by regulation, a goal of care which is set in long-term care, the files of long-term care for every patient. Unfortunately, because of behavioral and emotional factors, these goals of care are not necessarily followed. You may have like a goal of care which clearly states that the patient is not to be transferred to hospital, but when push comes to shove, or when an acute problem seems to arise, these goals of care are not necessarily followed because the families get emotional about the possibility that this could be a terminal event, and they change the direction of care to going to the hospital. This is transmitted to the RNA, who is the primary caregiver at bedside. And again, there are behavioral responses from the first-hand caregiver, where they can get as well a little bit overwhelmed by the presentation of someone in acute distress. Their training might be like not necessarily up to par to respond to these problems, and they are also bound by regulation, which says that basically, if a patient wants to go to hospital, if the patient himself or herself expresses whether they're demented or not, they have to be sent to the hospital, or they have to be their request has to be acted upon. This one would hope that this could be solved at some point by the RN, who is responsible for roughly 30 some patients, I believe, by regulation in the long-term care centers. And again, the training of that person, the reaction to the distress of the patient or the family might throw some of the the goals of care aside, which is unfortunate in a sense, because we're faced with factors that we can't really act upon when there's too much emotion involved. I've put there like nurse practitioner, which appears to be, from the experience, at least at the Civic Campus, appears to be a very significant improvement in counseling and guiding. It could be that the RNs and RNAs in the long-term care centers are very involved with families, have developed very strong emotional ties with patients or with families, which the consultant as a nurse practitioner doesn't have, because he or she are not in the location and can take a little bit more objective approach and saying, okay, well, why don't we try this before sending to the hospital? The problem with this nurse practitioner program, as effective as it has been, is that it's only available from Monday to Friday from, during opening hours, or maybe a few extended hours in the evening. Most of the time, during nights and weekends, we have to rely on a system of on-call physicians. The way, for those of us who work with long-term care centers, we know what happens. The physician who's on call is often on call for 6 or 7 centers with a number of patients which can be up to about 1,000. And basically, unless we are lucky enough that the physician on call works at this given center and knows about an individual patient, the reflex of the on-call physician will be, well, if the family wants, if the patient wants, if the nurse doesn't feel comfortable, well, let's just send the patient to hospital. So we're faced with an organizational problem here, whereby it is not imaginable that the physician on call could attend to 1,000 people at the bedside while being on call on a weekend, for example. We identified before that the paramedics are playing an ever-increasing role, for example, in triaging. Certainly when they're called, when 911 is called, they can go home and make a clinical decision, often based with a contact with a physician in emergency. And for example, if there's a chest pain patient with chest pain who has a normal EKG, who has a normal troponin point of care, the patient can be left at home because we've basically ruled out any emergency or any urgent medical problem which requires medical care. Unfortunately, and we've discovered this as we went along, if the paramedics go to a long-term care center, they cannot make that judgment. They can do an EKG, they can do a troponin point of care, they can do oxygen saturation, they can do their evaluation, but they still have to bring people to the hospital by regulation. So this is a major stumbling block in trying to optimize the care and provide the best care in the best location. And then we end up, the cascade leads us, of course, to another pivotal point, which is the emergency department, where many factors, and I can basically only talk about our environment at Montfort, where people are triaged, but with a lot of missing information, as we discovered. Patients are not flagged as being from a long-term care center. Many times the nursing staff involved in triaging, the physicians themselves, do not have a clear knowledge of whether patients are coming from a residence where they should be semi-autonomous or a long-term care center. Manoir Rockland and Manoir Laurier they're 2 manors, but they are very different in the scope of care they can provide. And unfortunately, we've identified with Diana Owen, our Director of Emergency, that this information is missing because we have a number of new physicians, some who are coming from outside Ottawa, and there's clearly a lack of knowledge of where people are coming from and what types of care can be provided, which leads to a consultation to the admissionist. Oftentimes, the first line will be the resident, first year or second year resident, who similarly does not have the knowledge of where the patient comes from. So it is extremely difficult to imagine an alternative to hospitalization, and then the cascade continues. And then I haven't put more. I say now we can talk about the care in hospital, but the main focus of our study was to look at the pre-hospital factors. So this is basically what we've come up with findings that were quite interesting in terms of regulation. Maybe next slide, Maddie. Yeah. So 3 paradigms come up. One is that there are a number of emotional factors and behaviors that are extremely difficult to predict and very difficult to act upon when a goal of care is clearly set, but changes at the last minute because of the acuity of a patient's presentation. The regulatory framework is very disconcerting when it comes to trying to have more constructive alternatives, especially when we discovered that the paramedics cannot, for example, calm down or put out a fire in the long-term care center, but they have to bring people. So this is extremely costly and probably not very productive, but we cannot act upon. The training and clinical judgment of people who work in long-term care is another challenge, which has started to be addressed by different projects like the LIN project that I mentioned in order to pass on these algorithms of care. Again, will people apply them when they're faced with an acute situation with a lot of patient distress? I don't know. That will be a challenge. So as next step, because of all these outside factors, which are very difficult to control because they're really out of our control, we can analyze them, but whether we can act upon them is very difficult. We thought that the next step would probably be to influence the last pivotal point, which is a triage in our emergency department. And certainly there's a lot of impetus from the hospital, from the emergency department, to try and gather a little bit more information to make it clear where the patients come from and what the resources are in a given healthcare center, like a long-term care center, in order to potentially avoid hospitalization. So the next step will basically be emphasizing this with the collaboration of our emergency department to try and influence a little bit, like a pivotal point where we can act upon. The other ones being extremely difficult. So this is my presentation. I think I've stuck to the time. Basically, what I'm looking for is like opinions. Maybe some of you have actually been involved in similar endeavors. I'm certainly looking for any collaboration from anyone who might have looked at this problematic before, analyzed it, and I'll be extremely happy to hear from anyone as we try to go into this second phase now. Thank you.
Pierre. Merci. That's fabulous. Very interesting work indeed.
Hi, Pierre. Great job. I totally agree with you. I experienced the same stuff when I worked Emerge in Perth over the years. And it's a Swiss cheese effect of people being accelerated into that pathway, come to Emerge, no one knows their past history. Then they get admitted and never leave, get over-investigated, cost a fortune. I think us family docs, we've dropped the ball to a certain extent in that we don't really have a strong active presence in looking after the elder care. As you mentioned, the demographics are such that the people graduating now are going to have to deal with a lot of older people. And at the Civic, we're kind of looking at potentially increasing our presence, exposing our learners, our trainers to long-term care homes. It's got to happen. It's unsustainable. Otherwise, all the beds are going to be filled. And then the real world, I think solutions might include something like having a more robust imaging service that goes to your long-term care home and does an x-ray right away, or does lab work right away. So you know if there's a fractured hip or something that has to go to emerge, and see what other things can be done. I know some cities in the States even have a mobile CT scanner that could go to an individual place and do a CAT scan of someone's brain to determine have they actually had a stroke or not, and do they need clot buster medication. But you identified a total schmoz, a system disorder. Well done. Thanks.
Thank you, Owen. Mary Helene, you have a comment or a question?
Yes, hi, thanks. Oui, merci Pierre. Comme Owen disait, I think this is a very important subject, and I think this is really something that we need to look into. And anyway, you know, they're looking into refurbishing long-term care in some manner. So maybe this is the timing, I think, would be excellent. And as Owen was saying, I know my mother was in a long-term care, she lived till 96, so she managed to get in long-term care somehow. And indeed, you know, the x-rays came to the long-term care. So you know whether they had pneumonia, whether they had a broken hip or whatever, whether you need to act or not. So I think this is, there are many things we can do. You know, as you say, finding an intervention, Pierre, the best thing first would be to find something very simple. If you're looking into just the triage at Montfort, you know, how best to inform the triage when people come. You know, maybe relook at the transfer note or harmonize the transfer note that the long-term care sent to the, you know, to have exactly the important information that you would want as the emergency physician, the level of care they have, the level, etc. So, I mean, I think that, I mean, it's enormous. It's enormous. So you have to pick one thing and try and work on one thing, which is simple. But I think this is something, the timing is good because they're looking into, you know, changing long-term care. There are major problems. As you say, the training of the staff there needs to be increased, how to do that. As Owen was saying, maybe getting us more involved too. Anyway, huge problems and a major problem, and the time is excellent. Thank you.
Yeah, I think the ultimate goal would be, as Owen says, and Marie-Hélène as well, to have a vertical integration, like, you know, blend in long-term care, acute care, maybe even with physicians who are involved at both levels in order to make it more fluid. Anyway, this is a little bit beyond the research, but as I said, it was an observational. I'm a rookie at this. This was an observational qualitative analysis. It led to interesting findings, and hopefully in our little community, it can lead to a little bit of changes. So, thank you for your comments.
Well, the first thing, if we could publish something, you could get some feedback from lots of Canadians and lots of deciders.
That's right. It sounds like it certainly is of interest and, you know, common issues across the country, I would think. So.
The nice thing about this forum that we've had is we've gone from you know, like very clinical, like my little piece, to Kayan's how would I say, attitudinal and mental health issues. So this is a very interesting forum because we go from one topic to the other, which just shows the breadth of interest as family physicians.
Yeah,
so
exactly.
Thank you for your comments, participation, and listening.
If you write up something, a few of us could review what you write, and we could make comments and improve, and we see where we can submit that. Owen, you would be ready to review?
Yeah, we haven't met Doyenne in a long time, so maybe we should get back together over a beer or something.
No, but I think it's the way of the future. Like, economics are going to make this happen. Like,
exactly.
Your children and your children's children are not going to pay for this chaotic, malfunctioning long-term care system. particularly when you look at countries like Denmark or whatever, where you already mentioned Chile, where people don't automatically get put into a retirement home. But I really feel that we've dropped the ball. You know, it's too easy to say go to a merge. And there should nearly be a sort of like maybe a 24, 48 hour holding thing in a merge where you have to prove you get admitted, that it's worth your while. Because sometimes it's simple things that happen, like a bit of Lasix here, a catheter there, some antibiotics for the cellulitis of the leg. These are the sort of quick things that you could then possibly go out before you get too habituated. Plus, coming into the merge is the wrong thing. You're stuck in bed, your quads muscles atrophy like immediately, your delirium chance. It's like a stress test for delirium coming into our new merge department. The giant tent that's been built in the Civic. It's cold as little old deers are freezing, they're shivering. There's no, you know, it's like a recipe for a disaster.
Yeah. It sounds, Owen, like I've found a co-researcher.
There you go. All right. Yeah, I'm getting up there myself, so I have to be aware of the options.
Well, let's plan for a beer soon.
Okay. All
Well,
right, gotta go.
On that note, thank you all very much. Kian, Pierre, wonderful presentations and discussions. I look forward to seeing you all next month. As you can see, it's the Civic Campus will be sharing some of their work. So until then, I wish you all a good day.